Hi everyone, my name is Dr. Ashley Alexis. I'm a menopause specialist, and today we're going to be diving into perimenopause and menopause and all the things that are associated with signs, symptoms, the experience, and things that you could do to help optimize your experience through the perimenopause transition into menopause. Remember, talk to your doctor about anything new that you're going to add to your routine as far as diet, supplements, and herbal recommendations, okay? All right, let's get started. What is perimenopause? The definition is the stage in menopause transition where changes in menstrual cycles and menopausal symptoms occur. Menstrual cycles can become irregular or start to skip months. So those fluctuations in your bleeding patterns are definitely a sign of perimenopause. And this starts on average between ages 42 and 50, but it can occur plus or minus a few years on either end. So women, we start to have hormonal changes in our 30s or mid to late 30s. So you can start to see these symptoms occur then as well. Now let's talk about the definitions and stages of that transition. So natural menopause is 12 months of no menstrual cycle, all right? Occurs around average age of 52, but again, plus or minus a few years on either side. Induced menopause is when menopause occurs through surgery or drugs. So with removal of both ovaries called a bilateral oophorectomy, that puts you immediately into menopause. Hysterectomy is just the removal of a uterus. So you're not in menopause after hysterectomy. But the medications that can cause menopause are, for example, chemo and radiation. And then early menopause is defined as menopause that occurs before the age of 45, and late menopause occurs after the age of 54. So some technical definitions there. One thing that's not on here is premature ovarian insufficiency. That is a diagnosis of early menopause, technically before the age of 40. All right, so let's talk about some symptoms. So a lot of these symptoms women can experience in perimenopause, maybe some, not all, maybe all, it just depends. So anxiety, depression, or exacerbation of these symptoms if they've had it before perimenopause, hot flashes, night sweats, low libido, or an inability or decreased climax, vaginal dryness, weight gain, brain fog, mood swings, memory loss, inability to concentrate or focus, irritability, skin and hair changes, fatigue, and insomnia. So it's a long list, but there's so many more that maybe not be as common. So other changes that you may experience, of course, is your cognitive changes, dental changes, ocular changes with dry eyes, even dry mouth can occur, maybe bloating, heart palpitations, aching joints. So these are, other common symptoms that can be a sign of hormonal changes as well. So let's talk about some specific symptoms. So with hot flashes, about 41% of women in perimenopause report hot flashes, and they can really vary in how they present. So they can go from mild to intense. Mild is just a quick flash without sweating. Moderate is, you do have some sweating, but it doesn't really bother or impair your daily activities. Severe sensation of sweating that makes you have to sit down and wait till the hot flash passes. And then the most frequent and intense hot flashes that can last longer than a few minutes and are pretty debilitating. And they can cause sleep disturbances, they can cause depression and cognitive issues. So there's a lot going on there with hot flashes. And for some women, it could really, really cause issues in their day-to-day life. And as far as the causes of hot flashes, there's a lot of some hypothesis or theories out there as to what's happening. It could be an issue with a center in the brain called the hypothalamus. It could be changes in thyroid, and not an issue with the brain, but more of how it's regulated. It could be through thyroid hormones. It could be through other issues with your central nervous system. So there's a lot of things going on, but we don't know exactly why hot flashes are occurring. Weight gain. Weight gain is definitely a common reported symptom of perimenopause as women start to notice a change in fat deposition in their body, or that, certain strategies of weight loss that they were using before no longer work. So you have changes in your metabolic activity in the body, you have hormonal changes, and then you have this change in this lean muscle to fat ratio. A lot of women, as we get older, we lose that lean muscle, and muscle is the most insulin sensitive tissue in the body, and it's the most metabolically active tissue in the body. Okay, so all of that combined, plus potential insulin resistance or dysregulated sugar metabolism in the body can lead to weight gain. So it's a multifactorial approach. But honestly, the main thing to focus on is calories in, calories out, along with some other approaches to making sure your thyroid is in balance. Your stress management practices are there, sleep management, of course, watching, your processed foods and sugar intake, and building muscle. Really got to focus on building muscle there. Mood swings. So mood swings are definitely a huge reported symptom and, affect, a large percentage of women in perimenopause. And they can go from depression and anxiety to irritability and anger. So it really depends. A lot of women will report crying on, from a commercial, just being a lot more sensitive to things, and or being reactive. They're noticing that they're short-tempered with their family members or their partners. And insomnia. So insomnia is a huge issue for women. About 46% of U.S. women between the ages of 40 and 50 are affected, and 48% of women between the ages of 55 and 64 are affected. So it's a huge risk factor for many things, for many illnesses, especially cardiovascular disease and cognitive function. And a lot of the hormone decline can lead to this, like low estrogen and low progesterone. Vaginal dryness. So this is unfortunately another common symptom that most women have in perimenopause or menopause, but only 7% of women actually report it because of feeling embarrassed or uncomfortable in sharing that with their provider. Okay, so estrogen, we have estrogen receptors all throughout their body, but especially in our vaginal tissue. And so as estrogen declines in perimenopause, we'll lose the blood flow and circulation to the area. The low estrogen affects the collagen and hyaluronic acid in the connective tissue in the vaginal area. It also affects the bacteria and pH. So women can also get UTIs as well, or yeast infections, or bacterial vaginosis. So changes in odor can occur. Then you have the loss of elasticity in the vaginal tissue, as far as also with the narrowing of the vaginal canal. So a lot of histological tissue changes with estrogen decline. And then low libido. So the desire for sex also decreases. And this is a huge reported symptom as well. Now, we need estrogen and we need testosterone to have a healthy libido. And we hit that estrogen peak on day 12 of our cycle, which we'll totally talk about in more depth. That stimulates a lot of testosterone receptors before ovulation. And that's what increases the desire in hopes, as far as our evolutionary makeup, to make a baby, to get pregnant. So libido is also affected by the mental emotional aspect. So there's a lot of life changes and physical changes that women go through in perimenopause. So it's assessing the relationship, intimacy in the relationship, and how close they feel and safe with their partner. It's how they feel about their bodies and how they look, and feeling sexy and feeling confident. All that comes into play when it comes to sexual desire. Now, the hormonal changes that occur are affected by most, if not all, of these hormones here: estrogen, cortisol output, DHEA. We have the thyroid hormones, free T3, free T4, FSH, which hormone that comes from the brain that we'll talk about, progesterone, prolactin, testosterone. So a lot of evaluation goes into this, which we're also going to do. But let's get an idea of what is actually happening in the menstrual cycle for a regularly menstruating woman, and then we'll see what happens as we transition into menopause. So this is a 1-month cycle or 28-day cycle. This is the average length of cycle. Now, women can vary, to 26 days or 32 days. But for the average woman, this is what a menstrual cycle is going to look like. At the top there, you'll see there's 2 phases. The first 2 weeks of the cycle is called the follicular phase. Then you have the last 2 weeks of the cycle called the luteal phase, and different things are happening at each time. So the first few days, you'll see that FSH just start to incline a little bit. Follicle stimulating hormone is a hormone that comes from our brain and talks to our ovaries. So that's the hormone that gets sent out to start getting things moving, to start getting the follicle released, to start building estrogen amount, all right? Then you'll see from day probably about 2 or 3 up until day 12, that yellow line, estrogen starts to build, okay? That's an important thing here. We need that whole building process and that peak on day 12 to signal the events that occur in the second half of the cycle. You'll see FSH continues to kind of plateau a little bit and then shoot up right before ovulation. You'll see the blue line, which is progesterone. Progesterone is flat until you ovulate after day 14, and then it starts to shoot up and peak around day 21. Okay, so these are all very important events that happen not only to prepare for pregnancy, but also when it comes to lab testing, which we'll talk about. Okay, so FSH, you'll see in the first couple days there, that's the best time to test FSH, between day 2 or 3. And then you see estrogen. To get the highest amount of estrogen of the month, you want to test on day 12. We'll all review this again in just a few minutes. And then to get the highest amount of progesterone, you want to test progesterone somewhere between days 19 and 22 of the cycle, because it makes sense. To have a blood panel done and you're in your follicular phase, I see this all the time. Doctors will put a progesterone there, and it's usually around 0. There's not a lot of progesterone being made, so there's no point in testing it during that time. It makes more sense to test it in the second half of the cycle. All right. And then LH is luteinizing hormone. That surge of LH is what also signals ovulation to occur. And then another important fact to point out, you notice progesterone is only made in the second half of the cycle because it only gets made after you ovulate. All right. So if you're not ovulating, you're not going to make progesterone, period. So a lot of times we'll see different bleeding patterns in perimenopause where you'll bleed normally in the first, 5 to 6 days. And then when you hit that 14-day mark, you start to bleed or spot again, and then you enter another full-blown period. Why is that? Well, if you didn't ovulate, you didn't make progesterone, and progesterone's job is to hold the uterine lining together. Okay. So that is a huge reason why testing matters. And also a huge reason why we have to know when spotting occurs. So if you're spotting after that day 14, it's more than likely that you didn't ovulate. Now, if you're spotting somewhere in the follicular phase, it could be that your estrogen is not getting to its peak, and you need that high enough estrogen to also hold that uterine lining together. So a lot goes into that. But just to give you an idea, I want you to have a good understanding of what's happening in your menstrual cycle. And then we'll see on this graph, so the vertical axis there shows the level of estrogen. We have our highest amount of estrogens between the age of 20 and about mid to late 30s. And then perimenopause starts, and you'll start to see that decline, and then that flat line through menopause and postmenopause. Postmenopause, that term literally means after a woman hit her 12 months of no cycle, the next day she's in postmenopause for the rest of her life. And then, of course, this is without hormone replacement therapy or supplementation. This will also give us a good idea of what's actually happening in perimenopause from a hormonal standpoint. So the first bar there, you'll see that 1 month cycle and the hormones that are produced there that we just reviewed a couple slides ago. Then you'll see that over 180 days, the cyclical pattern of the premenopausal normal cycles. Then you hit perimenopause, and it just looks like a bowl of spaghetti. So you see that estrogen solid yellow line is just all over the place. The FSH, the dashed lighter line is all over the place. There's no consistency here. And you can imagine with just slight changes, maybe in pre-menopause before peri's even hit, we have some hormonal changes that cause PMS or bloating. So imagine when it's like this, how like severe it can affect women. And that's why perimenopause can be the most tumultuous time through the whole menopause transition. And then we hit postmenopause, of course, where all the hormones are flatline. All right. So as I alluded to before, there are, mild to significant menstrual cycle changes that can happen. So cycles can become longer, shorter, more frequent. The bleeding patterns can change, either becoming heavier, lighter, or just have spotting intermittently throughout the cycle, or other changes like cramping, clotting, more PMS, and headaches can occur as well. So all of these are taken into account. There's not one lab test or one sign or symptom that will say that you're in perimenopause, but we take all this information and your age to kind of put that picture together. So the hormonal changes in perimenopause, your follicles decline. So what that means is you have the eggs in your ovary, those start to diminish, okay? As those start to diminish, then your overall hormone production starts to diminish. FSH, which comes from the pituitary gland in your brain, which is the signal that talks to your ovaries, starts to increase, okay? And that's why when we talk about lab testing, you'll see what the ranges are to say, okay, are you in the peri or menopausal range? Ovulation becomes infrequent. So the less follicles you have, the less you're going to be able to ovulate every month. And then estrogen production starts to decline overall. So let's get into the hormones, the main players here. All right, there's 3 types of estrogens that we make, okay? We are very familiar with estradiol, that's E2. That is the most abundant and the most potent form of estrogen in our body. That's what gives us our curves. That's what keeps us plump and juicy, our hair, skin, nails, and vaginas. That's what helps maintain our cardiovascular health, our cognitive health, our bone health, okay? And then as far as like libido and energy, all that is affected by estrogen. So estrone, known as E1, is highest in menopause, but is a weaker form of estrogen. And then estriol, E3, another weaker form of estrogen, is highest in pregnancy. But they intervert in between each other and have different actions and can be used in different ways in hormones. Now, we don't really use estrone, but estradiol and estriol are typically used in hormone replacement therapy. And then we have progesterone. Progesterone's our feel-good hormone. It keeps us calm, less anxious, helps us sleep. And progesterone has this ability to enter the blood through the blood-brain barrier and attaches to GABA receptors. GABA is a neurotransmitter in our brain that keeps us calm, reduces anxiety, and helps us sleep through the night, improving our quality of sleep as well. So it's also important, of course, for maintaining pregnancy. It keeps the uterine lining together. But we use progesterone to offset the stimulating effects of estrogen and hormone replacement therapy, but also because it does have those benefits as well. And then we have testosterone. This is our sexy hormone. Testosterone can help with our libido, with our confidence, motivation. And then we have DHEA. So DHEA is another androgen made in our adrenal glands that converts into testosterone. But that can be helpful for the similar symptoms or similar benefits that testosterone can give, but also has ability to lower inflammation and help with cognitive function as well. And one important thing to point out is that even though you may start to be noticing menopausal symptoms, changes in your blood flow, changes in your cycle, even if you're skipping months, you can possibly still get pregnant, okay? And your chances of having twins increases because that FSH, the follicle stimulating hormone that I pointed out earlier, so its role is to signal the ovaries to prepare follicles, okay? And so that FSH, because of the fluctuations throughout the cycle in perimenopause, it can stimulate more than one egg to be released before the start of the next cycle. So if you were tracking your cycles and you know your fertile window somewhere between days 12 and 16 and that, somewhere in there, and then you don't have sex during that time or use protection, and then you don't know that another egg was being released later in your cycle and you have unprotected sex, you can get pregnant twice technically, or, pregnant with twins. So that's something to be aware of in perimenopause. And then, in perimenopause and menopause, the changes in hormones can actually increase certain risks, okay? And once you get into menopause, when hormones are flatlined, that risk increases even more. So low estrogen, low progesterone can increase your risk for heart disease. And heart disease is the #1 killer for women in this country. It can increase risk for osteoporosis, neurodegenerative diseases like Alzheimer's, dementia, diabetes, and certain cancers. So when we talk about treatments and hormone replacement therapy, specifically, not only are we working to improve quality of life, reduce symptoms, we're also looking at longevity and protection against these diseases here. All right, let's talk about some lab testing really quickly. So for women that are cycling consistently, I mentioned the FSH being tested on day 2 or 3 of your cycle because that's when it starts to be produced. The FSH, if it's above 10, typically is perimenopausal ranges. Above 20 is menopausal, okay? And the FSH can also fluctuate month to month. So if you want to get a reading on day 2 or 3 of your cycle for 3 months in a row and take the average, it can give you an idea of where you land. that estradiol on day 12 is going to be the highest of the month. And so I'm looking for a healthy range between 3 and 350. Under that may indicate lower estrogen production. With progesterone, that day 21 is going to be significant for showing your level of progesterone production. A good level is above 10. And then in that luteal phase as well, somewhere between 19 and 21, you can also test your estradiol range. We do have a small peak there as well, and that a healthy level is around 150. So, we try our best to hit these peaks, but for women, it could be different. So instead of having a day 12 estrogen peak, you may be a day 11 or a day 13. So lab testing may not always be perfect in finding that peak for you. So we do the best that we can. We get as close as possible to that date. And then, use that in context when we're interpreting the lab results. And then we have some comprehensive lab testing. So besides the sex hormones, estrogen, progesterone, testosterone, total and free, they both tell you different things. We have DHEA, we have cortisol. Now, cortisol is super important because our adrenal output of cortisol can say a lot about, can exacerbate certain symptoms if it's dysregulated. But the gold standard way to test cortisol is through saliva. And then we have our full thyroid panel, TSH, free T3, free T4, and there are antibodies to rule in or out autoimmunity with the thyroid, like Hashimoto's, so anti-TPO, anti-TG. Reverse or RT3 is a good marker to use if there is chronic fatigue, because that can bind up thyroid hormones. Then we have FSH and LH and prolactin. Prolactin, when it's high, can cause, it can prevent ovulation. So we always check in on that as well. And then just a more comprehensive list. You want to look at your CBC to look at your red blood cells, your CMP to look at your liver and kidney function, your lipid panel, of course, to look at your HDL, LDL, cholesterol, and triglycerides. And then we have some inflammatory markers like homocysteine and CRP, and then iron and ferritin. If there's fatigue, we want to make sure that you're not anemic. But also ferritin can be elevated because it is considered a inflammatory mediator. So if there's inflammation in the body, I'll see that elevated. It'll also be elevated with hemochromatosis as well, which is a condition where your body can't get rid of iron. Vitamin D, LP(a) will show your genetic predisposition for cardiovascular disease, along with apolipoproteins. And then, of course, we get a fasting insulin and A1C to look at your metabolic health. And then for premature ovarian insufficiency, which I mentioned earlier, a test for that is anti-Müllerian hormone, and then there's some information there. So that's how we kind of diagnose POI for women that are not menstruating under the age of 40. Now we're going to talk about a very special test called the Dutch test. Now, I use this test for my patients to evaluate how their body is using estrogens. So this test shows us phase 1 and phase 2 of estrogen metabolism. So if you look at the pathways, the green, yellow, and blue arrows, that's phase 1 of estrogen metabolism. So after our body makes estrogen, it uses these pathways to break down estrogen. And it's very important to know these pathways because certain pathways are healthy and certain pathways can increase certain risks. So for example, the green pathway, the 2-hydroxy pathway, takes estrogens, binds them up, and then pushes them through phase 2 effectively so that they can be cleared out of the body. The red pathway, 4-hydroxy pathway, actually takes estrogens, turns them into DNA-damaging metabolites called quinones, and forces estrogens to remain in the body. So we want estrogens to be cleared out because estrogen is very stimulating. It grows tissue like our uterine lining that we shed every month in pre and perimenopause. But it also can cause endometriosis, fibroids, adenomyosis. It can exacerbate PMS. So we want those estrogens to be cleared out effectively so that when we make new estrogens, we have those fresh estrogens being made next month. So we use this test to kind of gauge where correction may need to be supported. So if the red pathway is used at a higher percent, and we can see that with the pie chart right next to it, then we can use certain nutrients like glutathione, resveratrol, DIM, calcium D-glucarate to correct and shift the pathways to the green one. And then in phase 2, which is that bottom section that veers to the left there, that is phase 2 of estrogen metabolism. And it goes through a process called methylation, which you'll see in that green arrow. And methylation is a process where your body attaches a methyl group to estrogen to tell the body that it's ready to be cleared out. And we want this process to be efficient. So if you look at that fan gauge there for this person, they have low methylation activity there. So if you see this, visualize this process as a faucet, okay? Go to the top of those red, blue, green arrows. That's the water coming down from the faucet. And then when it veers off to the left, that's the drain, okay? So this person's drain is a little bit clogged. So again, it's slowing down the estrogen clearance process, again, putting her at risk for exacerbated PMS or those high estrogen symptoms like fibroids or endometriosis, things like that. So we use certain nutrients here to correct this, like magnesium and other methyl donors like a methylated B12, B6, B folate, or B9. So we use this test to understand what her body's doing with estrogens that she's either making, or for a menopausal woman, say, who is on hormone replacement therapy, we get to see what her body is doing with the supplemental estrogen. And this is very important. Anything that causes DNA damage can potentially increase risk for cancer. We don't want that, especially in that 4OH pathway. So I use this test for those reasons. Now, we also get to look at the progesterone production. We also get to look at the androgens like testosterone, DHT, androstenedione, and other metabolites. And then another important part of this test is the adrenal function test, where we look at the cortisol output and the way that your body makes and the diurnal pattern of cortisol that should be made throughout the day. For this person, again, that red line is her, and we want to see in the middle section in that gray area, between that high and the low ranges. For this person, she was running on fumes, barely making any cortisol, and was probably really exhausted. So we use adrenal adaptogens to correct this for her and give her some support. So this is a wonderful test to get a comprehensive view of what your body's doing with hormones. It's not absolutely necessary. However, it can be really helpful when you're in perimenopause or considering doing HRT in menopause. And there's more information on my website on these tests if you're interested, and that's goldenleafhc.com. And you can look under the shop section. All right. And then, when it comes to certain nutrients in correcting estrogen metabolism, and when it comes to providing hormone support, there is Equia Balance. Now, Equia Balance is a great product, and it has certain nutrients and certain herbs that can be really helpful in perimenopause and for menopause as well. So chaste tree berry or vitex is a herb that's in here that's known for helping indirectly, but it can help with progesterone production and help with that luteal phase part of the cycle where progesterone's made and where PMS may be exacerbated. There's also black cohosh in here, which can be really helpful for hot flashes because of its phytoestrogenic activity, and can help with the other symptoms like night sweats and vaginal dryness and sleep issues. So it's a really good formula with black cohosh, which is a really well-known perimenopausal menopausal herb. And then resveratrol is also in here. That's one of the herbs that's used to correct and shift the pathway from red to green, which is a great antioxidant. It's cardioprotective, has anti-cancer properties, and also has a phytoestrogenic effect on the body as well. And additional things that are in this product is DIM, another herb or nutrient that's used to shift that green pathway. And then there's magnesium and B6 and B12 and folate, all the nutrients that can be used in that phase 2 of estrogen metabolism that was seen in the Dutch test as well. So this is a great formula to try and have during your perimenopausal transition. And if you're experiencing menopausal symptoms as well and aren't getting the support that's needed, you can try this product. It's on my website, goldenleafhc.com, and you can use a special code that will email you for 10% off. So through perimenopause and into menopause, foundations of health are going to be super important. So here's some lifestyle treatments that you can work on and improve to help reduce symptoms and optimize your experience through perimenopause and menopause. Focus on diet and nutrition. Exercise. Exercise is so important because of its wonderful effects against cardiovascular disease, cognitive decline, frailty in older age, cardiovascular health. So there's so many benefits to exercise, stress management, being a part of a community, and therapy as well. Okay, so let's get into some other non-hormonal options that may be helpful for reducing symptoms in perimenopause. And these can be various herbs, supplements, and products that you may find on the market. So for hot flashes, there are many things that you can try, like soy isoflavones, fish oils, vitamin E, black cohosh, an herb that's in Equia Balance, curcumin, also known as turmeric, can be really helpful for night sweat specifically, licorice, milk thistle, and fenugreek. And then we have depression and anxiety. So a lot of the B vitamins are going to be helpful for this. Then you have ginseng, maca, red clover, and then 5-HTP can also be helpful. And for anxiety, GABA. So GABA is a really important neurotransmitter, and you've heard this before when I talked about progesterone. But GABA can be given in a supplement. L-theanine, passion flower, ashwagandha can be helpful for that. For sleep, this is a major issue for a lot of women. Melatonin, 5-HTP, magnesium, valerian is a really good route for insomnia. L-tryptophan as well. So dry eye is another issue that can be common in menopause or perimenopause. And so fish oils and flax oil can be really helpful. And then for libido, maca is going to have a significant and can have a significant effect on increasing libido and just overall sexual function. Fenugreek and tribulus are also well-known herbs for that as well. And then for vaginal dryness, so there's certain things that you want to treat locally, and you can use vitamin E, vitamin D suppositories, and there are other hormonal options that we'll talk about in the next few minutes for vaginal dryness. So let's dive in finally to one of my favorite topics, which is HRT. All right, so let's break it down. Hormone replacement therapy is just an umbrella term for any type of hormone replacement. Like, you can replace thyroid hormones, for example. What we're talking about is for sex hormones, for menopausal hormone management, hormone treatment. So there are different types of HRT, okay? We have bioidentical and we have synthetic. So let's talk about what the differences are. So synthetic hormones are, in regards to estrogen, it's called conjugated equine estrogens, or CEE, and they're called that because they're derived from horse urine, okay? And then you have a synthetic progesterone, and they're called progestins, okay? Body identical or bioidentical, the names are just as is: estradiol, progesterone, testosterone. If it says anything other than that, it's not bioidentical. And then we have commercial FDA approved bioidentical and synthetic hormones, and then we have compounded bioidentical hormones, and we'll talk about the differences. In bioidentical hormone replacement therapy, it's derived from plants, okay? It's derived from a soybean or Mexican wild yam. And they extract certain compounds from plants, and two of them are called beta-sitosterol and diostrogen. And so basically those chemicals have a biochemical structure that's identical to ours. So it's identical to humans. And so it's like we're bringing our hormones back into our body versus a medication that acts on our receptors differently. And that is an important nuance. And so they take those compounds, they process them in the lab for us to be able to use them as hormones. And then, with the compounded hormones, so they're made in specialty compounding pharmacies where they actually make the hormones when it's ordered. And so I can order a, 0.5 milligram of estradiol cream, particularly for my patient based on what her specific needs are. And we have a lot more flexibility in dosing. Whereas a patch that's FDA and commercially available, is limited in dosing. And I get, for example, many patients that have been on the patch, the highest dose, and are still having hot flashes and other issues. So then we move to a cream to have more flexibility in dosing. So there's a lot of nuances there and differences and freedoms in our ability to make sure that we're getting rid of those symptoms and all of that in menopause and perimenopause. And then we have our synthetic hormones. So like I said, it's made from horse urine. And a synthetic estrogen is typically in Premarin, for example, or Prempro. And then Provera is the synthetic progesterone called a progestin, and it's also in Prempro with the synthetic estrogen. And you'll see various combinations in a combi patch or certain tablets of, bioidentical estrogen or in the synthetic progestin. So you'll see different things on the market now. So you'll see the list of names here. Like I said, it doesn't say estradiol by itself. It doesn't say progesterone by itself. So these are obviously synthetic. And they have different effects in the body. You'll see that oral estrogen, and this is key, oral estrogen, whether it's bioidentical or synthetic, will increase strokes, or risk for stroke, blood clotting factors, and versus a topical estradiol does not. So when that comes in a cream, gel, or patch, which we'll talk about right here. So here are all the forms that hormones can come in. You can take oral progesterone, oral estrogen. You can do estradiol and progesterone or progestin patches. You can do creams. You can do injections. And then other delivery methods are pellets, sprays, vaginal suppositories or vaginal creams. So we can really get into, really get creative with delivery of hormones sometimes. They'll have their benefits and their risks. Pellets, for example, is a huge industry, very, very costly. But you get a pellet inserted in your hip that remains there for 3 to 4 months. But you have to deal with the consequences of being overdosed or underdosed. And, that's unfortunate. So it's not a lot of safety data on that. And same thing with injections for women. We don't have a lot of safety data on that. So, it really just depends on the preference of the patient and the doctor and the way that they prescribe hormones. And so the benefits for women: reduces your hot flashes, it can treat your vaginal dryness and atrophy, prevent and lower your risk for cognitive decline, cardiovascular disease, and osteoporosis. So like I said earlier, not only are we working on lowering symptoms and improving your quality of life, but we're also thinking long-term and helping with your longevity so that you can live, well into your elder age with a good quality of life and not in pain and not having to be on all these medications. So if you're seeking support for perimenopause and menopause, you can start with your general practitioner or your OBGYN. One thing to keep in mind is doctors aren't trained in how to work with perimenopausal and menopausal patients in medical school. I certainly wasn't. And we have to spend time and energy outside of med school to learn and then put that in practice. So don't be surprised if you're not giving any of these options with your GP or OB when you talk about your hot flashes and you're maybe not fully into menopause, or they think that you're too, it's been too long in menopause and estrogen's not safe. There's a lot of research that we know they can use, but they may not be familiar with. So working with a menopause specialist and searching for one may be the best thing for you, unless you do have that unicorn GP or OB that really knows what they're doing in terms of hormone replacement therapy. And one way to gauge whether it's appropriate to work with your doctor in this regard is you could ask them questions. What is their experience with working with menopausal patients? What research have they read about it? What do they feel or think about hormone replacement therapy? You can use that to get an idea of where they stand and then decide, okay, should I seek or get a referral to a menopause specialist, or do I move forward with their recommendations? So I hope this was helpful in giving you a broad overview understanding of what's happening and what you could do to help and optimize your experience through menopause and perimenopause.